Hello, everyone. This is Christy Wergeen with Lake Superior Quality Innovation Network, and I would like to welcome you to Preventing the Decline in ADLS, Mobility Enhancement, and Restorative Nursing Programs. This webinar is intended for providers working with quality innovation networks in Alaska, Colorado, Hawaii, Illinois, Iowa, Kansas, Michigan, Minnesota, Montana, Nebraska, Nevada, New Mexico, North Dakota, Oregon, South Dakota, Utah, Wisconsin, and Wyoming. All lines will be muted during this webinar. At the end of the webinar, there will be a short time for questions, and you may also ask questions in chat. Hopefully, many of you are familiar with the National Nursing Home Quality Care Collaborative Change Package. This change package is a collection of great ideas and practices to create lasting change in your nursing home. It was developed from a series of 10 site visits to high-performing nursing homes across the country, and the themes that emerged regarding how they approached quality and carried out their work. In addition to the change concepts and action items included in the change package, there are also 3 change bundles. One of these change bundles shares practices to maintain and improve resident mobility. Use the link on this slide to review the change package and change bundles. One of the change package strategies that leads to improvement is to provide exceptional, compassionate clinical care that treats the whole person by striving to prevent problems and treat when necessary. We are pleased that our guest speaker, Jeri Lundgren, will be sharing with us ideas on how to prevent a decline as well as enhance residents' mobility. Ms. Lundgren has been working in long-term care since 1990, specializing in wound care nationally since 1994. She is board certified as a certified wound specialist by the American Board of Wound Management, and she's also a certified wound care nurse by the Ostomy and Continence Society. Her extensive national background in wound management and long-term care includes survey management, litigation support, wound care consultation, program development, and clinical expert for several state quality improvement organizations and departments of health. Her background also includes 4 years as a director of nurses in a long-term care facility. Currently, Ms. Lundgren is the president of Senior Providers Resource. I will now turn the presentation over to you, Jeri.
Thanks so much, Christy, and good afternoon, everybody. Welcome. At the end of today's program, we're going to describe the impact of immobility, and I think this is a really good starting point, and it's a good starting point for your staff to understand why immobility is such an issue. And we'll talk a little bit about exercise programs and restorative interventions that will help the residents to help maintain or improve their mobility, strength, and balance, and then also demonstrate how to document the mobility enhancement restorative nursing programs to capture on MDS and for those folks in Minnesota on that case mix system. It's very important to try and keep residents mobile. And I think in particular in our care setting, it's definitely a challenge for us. Typically, in the nursing home setting, they do come in for therapy, and we tend to have an isolation between therapy and what's happening within nursing. And many times, once therapy is discontinued, a lot of times what's got them to that point of mobility and improvement sometimes doesn't continue to happen. It's very important, though, to have that clinical foundation. So why is immobility something that we should be looking at, and why is it an issue? Overall, as humans, we are meant to be upright and mobile. It is not natural for us to be in a lying or sitting position for long periods of time. And our body, all of our systems, has optimal body functioning when we're upright for at least 16 hours a day. And when you really think of our nursing home residents, we're lucky just a couple hours, especially they might be up for meals and then getting back into bed or sitting in wheelchairs for prolonged periods of time. Now, what's interesting when I started studying and kind of looking in the world of immobility, and it kind of started with actually falls and what's the root cause, really the realization is that immobility is potentially the root cause for many of the issues that we deal with our residents in the nursing home setting. Falls in and of themselves are a mobility issue because it's due to balance, strength, and endurance issues. That's the cause of them. As a wound care specialist, shame on me. I never even thought of it. Obviously, someone's immobile, they're at high risk for skin breakdown, and many times we would just put interventions in place to combat the pressure without really thinking about, hey, maybe if we get these people more mobile. Incontinence and UTIs, a lot of our residents can form the functional incontinence, the inability to get to the bathroom due to physical impairments or lack of muscle control. Development of diseases, and we go through, I'll talk about how immobility can contribute and is a root cause to diabetes and affects the cardiac system. Definitely get weight loss and muscle wasting. You'd think that if you're not active, your muscles wouldn't waste away, but they actually do. It leads to depression, delirium, and confusion. It's the root cause to respiratory infections and constipation. And one area we never really thought about was staph injuries. In our industry, we have one of the most dangerous industries to work in as far as staph injuries because of the back injuries of moving residents. So when we have to move people, it can be a very unsteady and unsafe procedure to do. So it can lead to back injuries because the residents themselves can't move. So turning, repositioning, and transferring and locking residents a lot of times is the root cause to those back injuries. Now, when you look at the causes of immobility, when you look at diagnoses that lead to immobility, most of the primary admission diagnoses that we see coming into the nursing home already mean or render the resident to be immobile. So a lot of them are coming in due to fractures and strokes, obesity, you might be cognitive impairment, Parkinson's, cardiac disease, just overall weakness, those respiratory diseases, or maybe they're a new amputee. If they have visual impairments, it may lead to them not moving. And then maybe that history of falls or fear of falling, so therefore they don't want to move. So I'm not going to go through all these lists, but the point of this is many times the diagnosis themselves of why the primary reason they're coming in is going to render them immobile. One of the biggest issues that we have in the long-term care setting, however, is that the resident may be moving too slow or taking too long. So ironically, us as staff caring for our residents are the root cause or the cause of the person becoming very immobile. We tend to do for them, it's much faster for us to plop them into a wheelchair and whip them down to the dining room and take their time to actually walk them down to the dining room. And even simple functions as brushing their teeth and doing their daily cares of washing their face, etc., those are all forms of exercise, and many times if we start doing all those things for them, we are going to further impair or render the resident immobile. I personally had an experience with a friend who was out of state, and their father was 98 years old, and he was independent on his own. He was alert and orientated. He was continent. He was mobile. He was still driving. He actually had a mild heart attack, and he drove himself into the ER. He ended up being admitted into a nursing home because they were having difficulty managing his medications. He had never been on anything, and he had gotten very weak in the hospital, so he came for some rehab. My good friend walked him into the facility and stated, he was a very, very slow walker. Over time, what happened with him is they were afraid that he'd fall. They put alarms on him, so he was afraid to get up, told him not to get up to go to the bathroom unless they came, and essentially told him not to get out of bed without help or assistance. And due to his walking too slow, they put him into a wheelchair. Long story short, he degenerated within a very quick period of time, within 3 months, and basically passed away. The diagnosis was failure to thrive, but one of the biggest issues was due to the fact that he was so immobile, he declined very rapidly. He is an extreme example. What I'm going to walk through is the effects of immobility that were done on a study that it was college students that were put on bed rest. So we're talking, and they're also athletic. So it was athletic college students that were in their 20s. They put them on bed rest and looked at the side effects of it. And it's amazing what I'm going to walk you through of what they saw that affected the body systems. It essentially affected all body systems on these young, healthy adults. So you can imagine when I talk about some of the time frames of these effects, can you imagine now you're in your upper 70s, 80s, and 98 years old, how quickly these effects can start hitting. One of the main effects that hits is that loss of independence and the psychosocial effects to it. there's always that fear of being admitted to that nursing home because they're no longer mobile at home. Overall, the effects on the muscle is there's a 12% rate of loss of muscle strength and atrophy or wasting away that muscle in as quickly as 1 week on that healthy adult. And as little as 3 to 5 weeks of immobility, almost half of the normal muscle strength is lost. That's absolutely incredible, and that, again, is on somebody who's healthy. I always kind of use the analogy, too, I think of when I exercise. All of you out there have ever been on an exercise program. It takes you forever to get up to a certain point, and then heaven forbid you stop for a week or two or you go on vacation. When you go back to do those same exercises, many times you can't do it at the performance level as you did the prior week or two. It takes you a while to get that back. So I think we've all experienced that sensation of losing that strength and ability quickly. The very first muscles to become weak are, unfortunately, those lower limbs. So it's that leg strength. So that'll further render that ability to be able to get up and to move. And keeping a muscle in a contracted position will significantly increase that atrophy. So not only if they're not moving the limbs, but if they hold it in a certain position, those muscles will continue to atrophy even at a higher rate. In stroke paralysis or immobility due to splinting, muscles atrophy about 30 to 40%. With that being said, on the healthy adults that were part of the study, it took 4 weeks to recover from the atrophy with exercise. So again, that's on a healthy adult with a very regimented exercise program. The unfortunate thing is total degenerated muscles are permanently replaced by fat and connective tissue. So once they're gone, you cannot get them back. And in the study, even though it took them about 4 weeks to get back from that atrophy, none of them were back to the performance level they were prior to the study. And the disuse of the muscle will also affect that neuromuscular function. So essentially the body forgets how to properly coordinate the motor function. You know, you look at a dancer or like a figure skater in the Olympics and they have to practice that routine over and over and over again. And what happens is they get muscle memory. And you'll talk with athletes that they don't practice it consistently, they will lose that and forget their routine. And we see it in the elderly. You always wonder when you go to transfer somebody, you know, will be standing to transfer, okay, you know, Mr. Smith, could you move your right leg? You need to pivot, and you see that hesitation or that leg shaking, and you can see that thought process where they're just really having difficulty even doing something as simple as a pivot transfer, and that's due to that effect of losing that neuromuscular function and that muscle memory. Also what happens is complete rest will decrease those endurance levels. So it'll cause, and it kind of gets an secular effect. So once you lose those endurance levels, it causes even more fatigue, which affects that motivation, which will then lead to greater inactivity. One would think, hey, if I rested for a while, I'll have more energy. It's exactly the opposite. You always hear the saying, a body in motion stays in motion. And I think, again, I know personally, when I don't exercise, it's really hard for me to get back in the routine and versus trying to stick with it. And keep going. On the connective tissue, so your connective tissue is your tendons, your ligaments, and your articular cartilage, which covers the joint. And as quickly as 4 to 6 days after immobility, changes in the structure and function of that connective tissue became apparent on these young adults. And the unfortunate thing is these changes remain even after normal activity has been resumed. Sorry about that, everyone. So my clicker gets a little crazy here. When it comes to contractures, so contractures are a decrease in the normal range in the parts of the body responsible for motion. So it's that both the cartilage and the related muscle. And as little as 2 to 3 weeks of immobilization, a firm contracture can develop. And I think we see that all the time with our stroke residents coming in, that a lot of times by the time we get them, many of those contractures are already well set in. And after 2 to 3 months of immobility, surgical correction may even be needed. The bone is also affected. And what happens is even if the person wasn't prone to osteoporosis, they can get what's called diffuse osteoporosis. And unfortunately, the bones that are most susceptible are the vertebrae, the long bones of the leg, heels and wrists, and those are all those bones that are very susceptible for when somebody falls, especially if they're breaking their fall, that they're going to, break those wrists, those arms, and then definitely their legs. Within 3 weeks of immobilization, pulse and clearance is 4 to 6 times higher than normal, and then hypocaust calcemia actually can occur, which that can lead to kidney stones, and it actually can affect their appetite, so they can get anorexia, nausea, and vomiting. And sometimes they're not thinking that maybe due to the fact that they're immobile is why they're losing their actual appetite. Skin. As you're sitting here listening to me, you guys are all squirming around and shifting your weight, and we even do that subconsciously when we sleep. What happens with immobility or decreased sensation prevents that shifting of weight. So if you sit in one area for a prolonged period of time, the pressure to that skin can lead to that pressure ulcer formation. So immobility, and even the NQAP new guidelines state that immobility is the #1 risk factor for the formation of pressure ulcers. What's interesting when you think about it, the only area on your body designed to bear weight is the soles of your feet. And when you think of how small your feet are, you should be thanking your feet right now. It's amazing the weight and what our feet actually endure, especially when you deal with residents that get sitting type ulcers. I mean, our bottoms are definitely much bigger than our feet, so you'd think they'd be less prone to breakdown because there's more surface area, but that's just not the case. So very important to keep those residents up and to be moving. Also, once they become totally dependent on us to move them in bed, so they no longer can move themselves around, it also increases our risk for shear and friction, depending on how the staff move them. So that can lead to further skin breakdown. And then the skin next to the bed sheets can cause that moisture and lead to moisture-related skin concerns. On the overall cardiac system, when somebody's confined to bed, what happens is there are shifts of fluids away from the legs towards the abdomen, thorax, and head. And in as little as 24 hours, you can have a shift of 1 liter of fluid from the legs to the chest. So think about all your CHF residents or anybody with pulmonary issues, things like that, how dangerous for them to be confined to the bed. So what happens is you get increased venous return to the heart and elevated intracardial pressure. And the body's response to that is it's going to react to it. So even if the actual fluid volume is normal, because it's been shifted up to that thoracic area, it's going to respond to that. And so once the venous return stretch of that right atrium starts happening, the body's going to say, we have too much fluid. We're on overload, so it's going to stimulate diuretics. So it's going to increase the urine output and decrease the blood volume, so it actually leads to dehydration of our residents. And a lot of times we may see it over a quick period, and you might want to think if your residents get dehydrated, look at what their routine was. Hey, were they lying in bed for a long period of time? Also, when you look at the legs, immobility leads to that atrophy and loss of muscle mass in the legs. And so it impairs the muscle pump action, which reduces your venous return. So a lot of our residents that have that lower extremity edema, it could be secondary to the fact that they've just been immobile and they've lost that muscle pump action to get that blood back up. And then obviously your heart is a muscle too, so it needs activity to stay healthy. And immobility will lead to atrophy of that heart muscle. So really looking at those cardiac residents coming in, especially with their whole rehospitalization, really looking at your cardiac program to make sure that exercise is an active part of that. The other interesting piece of the cardiac system is postural hypotension. So a drop in the blood pressure upon standing is noted in as little as 20 hours of immobility. I think if any of you ever had any kind of surgery done, and if you've ever worked, in a post-surgical area, I've never met anybody, including myself, that after surgery, when you go to stand up for the first time, don't experience that kind of dizzy, low weakness. And imagine a resident now that's very elderly, someone very healthy in as little as 20 hours can get postural hypotension. Just think how quickly it can happen to a resident. Studies have proven that most falls happen around the bed. So it definitely could be that hypotensive response, so leading to that dizziness, anxiety, and falls. And what's interesting about that hypotension is many times we contribute it to the medications. We kind of look at that and kind of draw a blank sometimes. Really look at their activity level, and that could be why they're having that response. What was interesting is even in fit, healthy adults, it could take several weeks to fully recover once they start moving again. So the effects can last for a long period of time before they stop having that sensation. Overall, on the respiratory system, I don't think we always think about the fact that our rib cage is actually joints and can actually have contractures of it, leading to that inability to expand the lungs. So you have the risk of lungs collapsing. And then certainly the pooling of the mucus in the lower airways. So they have that increased risk of respiratory infections. Studies have shown that stroke patients can find a bed for 13 days or more, and many times they spend the majority of time in bed are two to three times more likely to develop those respiratory infections than mobile people. So really looking at that again, if your folks are chronically getting respiratory issues, yes, look at the big picture, but also look at that mobility level. Hematological effects is you have decreased oxygen saturation. And what's interesting about that is you'll have that decrease in oxygen saturation and increase in carbon dioxide concentration, which leads to hypoxia. And it can happen in a very short period of time. So it can lead to acute confusion. It can develop quickly over a number of hours of being bedbound, and the symptoms can fluctuate during the day and worsen at night. I would challenge you to kind of look at some of your residents, especially those that have some sundowner issues. Look at their activity levels during the day and when they're sundowning, and you might want to check their oxygen saturation levels to see where they're at. It could be that they are having a hypoxia response from not being active all day. Also, 13% of patients in bed for long periods of time may end up developing deep vein thrombosis. So that risk of DVTs and even that increased risk for emboli from not moving around. I think all of us know the effects on the gastrointestinal is obviously it can lead to constipation and fecal impaction. So again, if you have a resident that constantly is having issues with constipation, not only looking at fluid and fiber, but really look at their activity level to see if maybe that can help and make a difference. The other interesting thing is the mechanism of swallowing actually uses muscles. So it can actually lead to decrease and difficulty in swallowing. And then also, again, it can affect that anorexia. So it reduces the sense of taste, smell, and loss of appetite. On the overall endocrine system, I think this is one of the most interesting areas, is on healthy adults, again in the study, a decrease in metabolic rate in as little as 10 hours of being immobile, you develop insulin resistance. So you can have impaired glucose tolerance and the subsequent development of type 2 diabetes. I think that statement right there is very impactful, especially if you have residents who are really having trouble controlling their blood sugar despite maybe having a very controlled diet and insulin, really looking at that activity level and getting them up and getting them moving to help with that insulin resistance. On the renal system, we already talked about the kidney stones, but again, your bladder is a muscle. So it can lead to that urinary retention, so that overflow, which therefore can lead to urinary tract infections if that urine sits there in the bladder. It can also develop those urinary tract infections because the immobility could lead to incontinence due to the inability to get themselves to the bathroom. Therefore, it increases that risk for urinary tract infections and that urosepsis. The nervous system has a tremendous impact. Basically, what happens is you become sensory deprived. And when that happens, it will lead to depression, disorientation. They become very agitated, restless, confused, and they get that anxiety. You would think, again, if you're resting, you'd be all calm and relaxed, but immobility is very stressful on that nervous system. So when you think of a lot of your residents where they're having that agitation, restlessness, you might want to look at timing during the day when that's happening, and again, look at what the prior activity levels were. It's also interesting, too, because it will reduce the pain threshold. So if you have that resident that's constantly, when you go to move them, again, it could be due to that immobility is affecting that nervous system, which really does reduce that pain threshold. They'll have difficulty problem solving, and then they just have an overall loss of motivation. The other system that's affected with the nervous system is it will lead to insomnia. So the more you lay around, the more difficult it is to get a full, good night's rest. So it'll lead to that insomnia. As we said at the beginning, 16 hours of activity is what we need for optimal function and about 7 to 8 hours of truly uninterrupted sleep. And I don't know any residents truly in the nursing home setting that are allowed to get 7 to 8 hours of uninterrupted sleep at night and that are kept active for 16 hours out of the day. It just doesn't happen. And studies have shown consistently sleeping for more than 9 hours or fewer than 8 hours has a negative impact on not only the physical functions, but the psychosocial and cognitive functions of your residents. And some newer studies are showing that the importance of actually being very active and getting good sleep has an impact on the gray matter that affects, or the plaque that affects Alzheimer's and dementia. So another motivation to really kind of look at that activity level and what's happening at night. So with all those goodies that we have to look forward to with being immobile, how do we prevent the effects of immobility? First and foremost, it starts with the leadership really having buy-in that this is something that's very important to do. It's a very challenging thing to do, especially with their staffing levels and ratios with residents in facilities. So you really do have to have that administrator, DON, and management fully supporting the program and really being actively involved with it and committed to the program. So making sure that the right resources are there and that you're really working with those systems. So really a starting point is you might just want to do an assessment of currently what's happening right now in your nursing home. So, what is the overall mindset of staff? Do we even think of it? Is immobility even something that even is looked on the radar scale, and has anybody been concerned about the mobility level of your current residents? Look at how many residents depend on wheelchairs for mobility. How many of them truly need a wheelchair and should be using a wheelchair? And if they are supposed to actually or truly do need the wheelchair, are we allowing them to self-propel and be mobile if they're capable of doing that? Very important is that's what's the relationship between nursing, therapy, and activities. And that's a very important relationship. It's always interesting to me, and I fully admit it when I was a DON and, working in nursing homes, if someone were to ask me what my residents were doing as a nurse in therapy and what they were working on, I could honestly, I have no idea. And many times, if you ask a nurse, so what is therapy doing with them? There's a huge disconnect from there. And many times they get discharged from therapy, and the therapy ends. Here got into this great functioning level and a good maintenance level, and it ends. They're brought to nursing, and it's not continued or brought forward. And we really don't look at it. It doesn't have to be just the nursing therapy concern. There's a lot we can do with all the peripheral staff, especially during activities. Another question to ask is, do you currently have a restorative nursing program, and what does that actually provide? So right now, are you actually doing the minimum? Is your nursing assistants in particular, do they understand restorative nursing and the importance of promoting that independence of that resident? Or are the nursing assistants just kind of programmed to be task-oriented and to get the job done? So looking at is, do you even have the basics right now on the restorative and really promoting that independence for that resident? That might be the place that you need to start. And do your nursing assistants know how to identify the resident that should be in restorative nursing and working on those certain interventions? Really looking at your activities during the day and evenings, and as we kind of watch these, there's a lot of things during activities that you can do that promote activity or, being actually mobile and active. And not only can a lot of the activities help with them being active, there's a lot they can do with activities that also have things with coordination and actually have to use brain function, so thinking ability as well. Depending on the level of your resident, they might start with just more of the physical activity, but then you might be able to add to that activity, different, mental challenges as well. So kind of looking at that. And then kind of the very last gold standard out there, which is once you get kind of through everything else and get the program, is do you even have a sleep hygiene program where we train automatically to knock on doors every 2 hours and interrupt that sleep? So really kind of looking at the nighttime, and is your facility putting everybody to bed by 7 at night, and not getting them up until 7 or 8. So really looking at that sleep program. One great place to start, if you decide this is something that you definitely are interested in working with in your home, is you need to get your staff on board. So a lot of them at first are going to see this as, this is just more work, I don't have time, why are we doing this? So really starting out with this first half of the presentation I did, the clinical foundation as to why immobility is such an issue and why we should address it, will help to get their buy-in, especially when you kind of bring it back to look if they're having issues with falls or skin breakdown, or people are declining in ADLs, it could be due to the fact, they're being immobile. Really, your overall goal is to aim towards independence on how to, rather than doing for the resident. So really having that kind of mindset with all staff in the facility. And it's kind of instinctive, you always kind of want to do it, especially if you see them kind of struggling or taking a while for them to do something. Very important that everyone has that mindset that we want to promote that independence. First thing you might want to look at is your team. Who do you need on board? And it should be not only your interdisciplinary team, but you really need to make sure that you have therapy, your restorative nursing, so who are going to be your lead nurses and lead nursing assistants. So with that being said, many of the facilities I work with that have a quote-unquote restorative nursing program, it's one aide and one nurse. Well, one aide and one nurse can't possibly have the impact on a home as if you involve all your nursing assistants and all your floor nurses and really have those restorative nursing assistants and nurses kind of oversee the program and work with all of the staff. And also very important because we're going to talk about kind of adding in exercise programs, moving restorative nursing to be a little bit more fruitful. You really need your physicians and nurse practitioners on board so that they can make sure that they're writing the orders and making sure that that they're on board with it and that they are giving the green light that it's safe and okay for the resident to actually participate. Very important, we already talked about activities. Dietary is a big piece, especially if you are adding more activity to them. They need to make sure they're getting enough calorie counts for the type of energy expenditure they're actually going to be doing with it. And I know it sounds odd, maintenance and housekeeping, but we're going to talk about the environment, how to set that up, and they're very important to be a part of it because we want an environment that promotes mobility. And sometimes the most aesthetic, pretty-looking environments don't promote mobility. So we'll kind of talk about that. For best practice for the coordination of the program, what I strongly recommend is that therapy and nursing maybe really start working together and then pull in activities. But really, we recommend that a therapist do an initial assessment and setting up of the individual residence program for nursing or the designee to make sure it's safe and appropriate. From there, then therapy turns it over to nursing, but what therapy should do then is competency test that nursing department on implementing that individual residence program. So whatever it is they come up to that individual resident, that nursing does a competency testing to show that they're performing it appropriate for that individual resident. From there, then really talking and teaching nursing when they should refer back to therapy when the resident needs an adjustment of the program. So with that individual, therapy might say, look, if they're having a decline or if they're plateaued or if they need more aggressive exercises or if they're starting to say pain that's not associated with just normal, kind of exercise use or change the ability to perform exercises. So really having an understanding when we need to go back to therapy to kind of readjust that program. From there, making sure the physician approves and orders the exercise program, and then also to make sure, again, that dietary is involved to ensure proper calories and protein intake for the level of exercises. Now, with any QAPI program, you obviously need benchmarking data. So for facility, for the global benchmarking data, you might want to look at your quality measures under that long stay, so the percentage of residents experience one or more falls with a major injury, or falls or activities of daily living has increased. So that might be some benchmarking that you might want to start with. You could even look at, pressure ulcers, or even UTIs if you're kind of knowing that the root cause might be due to immobility. From there, what I strongly recommend is that you set up individual resident benchmarking goals. And this is very important for both the MDS. You have to have measurable goals for that resident. And for you folks in Minnesota in particular, case mix, the number one reason it's thrown out or restorative nursing is thrown out is because you don't have measurable goals. So I'm going to just kind of quickly walk you through some tests that you might want to consider for benchmarking data for your residents. And many of these tests, if you talk to therapy, they're already doing them. There's no reason why nursing can't continue to do these, and it's great benchmarking to see if the resident is improving. All of these tests are evidence-based, and as I walk through them, you'll see it's actually a little creepy. They have predictability of adverse outcomes, depending on where your resident falls. So the first one is the short physical performance battery test, and it involves 3 tests. So the chair rise test, the balance test, and the usual gait speed. So you do all 3 tests, and then it has a scoring system to that. And you'll see on here, if they score 0 to 5, they are at high risk for adverse outcomes. So this is your residents that are going to, potentially have issues or be rehospitalized. 6 to 8 approaching higher risk for adverse outcomes, and then 9 and above is more acceptable and desirable. On the individual test within that, the gait speed is also a big indicator. So if they have a very slow gait speed below the 1, they're at very high risk for poor health and function. And gait speed's been very highly related to that, the slower the gait speed, the shorter mortality that they actually have. So very important to kind of look at that gait speed, and if you can improve it, it's going to help improve that health and overall function. The balance test from the SPPD test can be a great starting point for the capabilities of your exercise program. So you might want to start with, somebody might not even have good sitting ability. So there's no reason that they still can't do some exercises in that supine position. So the balance test can help you determine, where you're going to start them on your exercise program in a lying, sitting, or a supported standing position, or will they be independent? Another test to consider is hand grip strength. Hand grip strength has been shown to be an indicator of overall muscle quality and strength. So it sounds odd, but it'll tell you the overall quality of the muscles throughout the body. So we definitely want them desirable. So we're trying to make them stronger because we definitely don't want that weak. So it's a very easy, quick test that you can do for that hand grip for benchmarking. Body mass index also, to make sure that they're in that healthy range or trying to get the goals for that. And another test is a muscle quality index. And the formula's right here. It's kind of a strange little formula, but what the muscle quality index, even though it hasn't been associated to determine if they'll have adverse outcomes or not, so it doesn't equate that if it equals this, that they're definitely going to have adverse outcomes. But why you'd want to consider it's a very sensitive test, and it detects sensitive changes in the person's functional status. So it's a great way to pick up if they're getting subtle changes, and really what your goal is to see an increase in the muscle quality index. From there, looking at steps per day, and I know a lot of goals is that they're going to walk 150 feet. I really would challenge you or push you to get it more to the steps per day. We all have heard the 10,000 steps per day for healthy adults. However, studies have shown, especially in the elderly, if men can get at least 5,500 steps per day and women 4,500 steps per day, it will increase their quality of life. So really looking at a 10-minute walk is comparable to 1,000 steps depending on walking speed and stepping cadence. And from there, so what you might want to do is I would maybe time them on their walk and track their actual steps. And from there, then the goal might be to add 100 to 1,000 steps per day, depending on the capabilities of that resident. And then maybe you can work the goal up to 10,000, so putting those pedometers on them. What we do recommend to get the baseline with the pedometer is put it on them just for 3 days, just doing the normal activities. And do it for at least 3 full days and track it, because they might have one really good day and one that might be a bad day. So you want to do 3 days to kind of get the average. So that'll give you kind of a baseline of what they're doing in a day. And then from there, it can help start adding different goals to that. It is important to understand the coding if you're trying to capture this in MDS. So there is some benefit here that you can actually get them into a higher run and get a little reimbursement out of it. But it's very important that the technique is done for at least 15 minutes in a 24-hour period. And that 15 minutes can be broken up as long as it's the same task. So this example uses a splint. So it's to remove and clean splint, inspect the skin, and perform range of motion for a total of 5 minutes 3 times a day. So that would count if it's broken up. But you couldn't do 15 minutes where it was 5 minutes of walking, 5 minutes of the splint, and 5 minutes of practicing bed transfer. So it has to be the same task. In order to hit the higher rug, you do need 2 or more 15-minute restorative programs for at least 6 to 7 days a week. And the restorative nursing, you can, if you do it for 4 people or lower, it can be counted. But for groups higher than 4, it can no longer be counted. And again, that's kind of a safety reason. So when you look at that restorative nursing program, just some things to highlight here, those ones on the screen here that have 2 stars, they count as one activity. So you couldn't say that I'm on a urinary palliative program and the second program is a bowel. That's considered one. Same with you can't do passive. So let's say if someone has a stroke, or you might be doing passive on one side, but they're doing active range of motion on the other. That's considered one service. And the same with, unfortunately, mobility, bed mobility. So if they're practicing bed mobility and walking training, that also counts only as one. What's interesting, and we don't think outside the box a lot, is that restorative nursing program MDS requirements for range of motion, active range of motion, it says code exercises performed by the resident with cueing, supervision, or physical assistance by staff that are individualized to that resident's needs, planned, monitored, evaluated, and documented in the medical record. Include active range of motion and active assisted range of motion. This is where the door opens, where it doesn't have to be just our range of motion where they're just moving their limbs. Add some weights to it and make it become an exercise and an exercise program, so it can be coded under that. So 2 examples then could be an active exercise, so that would go under the range of motion, and then maybe a walking program that you might put together, or range of motion and practicing transfers or bed mobility, etc. From there, it's very important that you have a separate restorative care plan and that you have, again, those measurable objectives and interventions, which I just gave you some great benchmarking data for that you have periodic evaluation, and that ensuring that your nursing assistants, already talked about that, are trained on the techniques, and that a registered nurse or LPN actually supervises activity in the restorative nursing program. So we're going to want to see notes, and what I recommend here is either maybe once a month or quarterly. Actually, weekly, I'd have the restorative nurse looking at the documentation, but then from there, you might want to relook at the benchmarking. You might want to start with it monthly and then maybe move it to quarterly, where you're doing those benchmarking data, so the grip strength, chair rise, those different tests to assess where they're at. I'm not going to spend a lot of time on these, but what we'll capture under Part A, so these next slides, you can refer back to them. So to capture under Part A, that was a requirement. Under Part B, don't forget about that. Just because they're off the A, if they are declining or need some assistance with exercise and restorative, you can send them to therapy. Therapy can set up that functional maintenance program, and they can capture it under Part B and turn it back over to nursing. And then from there, it goes to maintenance, which is nursing doing it. Okay. What's very important, too, on this is I have so many administrators and so many folks saying, I don't get paid, so I'm not going to do it. This should not drive it. Or I have a resident that does really well, but we can only get them to do it 3 times a week. Please do not let reimbursement drive what you're going to do. So still, please implement these programs. If you can capture the reimbursement, that's even an extra benefit. But the overall benefits that you'll get for your residents are well worth it. What you want to do is look at exercises, and you may want to look at some local gyms if you've got personal trainers in the area, or work with your therapy department. A lot of times therapies like, no one's ever asked me to do this. I could do this for you. Develop exercises that can be done individually or in groups of 4 that are done in 15-minute increments. And make sure, and that's the difference between therapy and true exercise physiology. Exercise physiology looks at the whole body, where therapy many times is targeted to maybe that hip fracture. So really having therapy set up an exercise program that utilizes the full body, so that will promote strength, range of motion, flexibility, cardiac output, blood flow, postural awareness, and balance. So really looking at that. And then again, get exercise that can do in a supine sitting, or If you have somebody who has some balance issues, but they can stand, it's not an issue, it's just some balance issues that you're concerned they might fall or hurt themselves or staff, you can use a assisted standing device. And put them in a standing device, they can still do their exercises, and that way they're still bearing weight and getting more benefit, and then having those that can do it, unassisted and standing. Very important exercise that can be done during activities. Treasure hunts and obstacle courses are one of the best ways to help prevent falls, especially with your Parkinson's, Alzheimer's, dementia residents. One of the reasons they fall is they lose the ability to pivot. They will totally set off their sensations, and it will lead them to fall. So having them do little obstacle courses or treasure hunts can help them with those pivot-type motions. A lot of your video exercise games are out there that can help with that. Even something as simple as throwing a ball, because it's that eye-hand coordination and it's exercise. Tai Chi is one of the best things that can be done for the elderly. So it will help with strength, flexibility, and that sense of body posture. Yoga, dancing, walking courses, and then even doing activities while standing. So if you're doing cooking or arts and crafts, have them do it. Have a high top table where they're in a standing position and kind of spread out the programs to offer it during the day and get them active in the evening. Kind of was a misnomer. A lot of people thought, and I was one of those, that if you exercise, and you shouldn't exercise really late at night. So exercise in the evening up to about 8 p.m. A lot of people thought, well, if I exercise in the evening, I won't sleep. Studies have shown that if you do it before 8 p.m., it actually helps sleep. So it can help promote that. So keeping them active in the morning and then active again in the evening can help with that sleep. I think all of us have had those days like, man, I went in the garden all day and I'm going to sleep really good tonight. When you think of those days you're really active, those are the times you get the best rest. So make sure we already talked about training all your staff, so not just restorative, train all your staff on how to do your restorative nursing and these exercise programs because they can actively be involved and should be. Environment evaluation is very important. You'll see in this picture, look at that shiny, non-contrasting hallway. You wonder why residents slip and fall, especially if they have poor vision. They don't have any depth perception here. So really making sure I know, and when I was a DON, every one of my facilities could come in, we had the shiny floors. It was like the cleanest facility, and now I know the glare of it was probably the worst thing we could have done because it will lead to that depth perception issues when they're trying to walk down the hall. So making sure that you don't have shiny, slippery floors, and make sure that the surfaces don't change. I was in one building that had the most beautiful tile, and it was carpet, and the poor little residents going across with their walkers going across that tile, and then they hit that carpet. It was like, it was just a fall waiting to happen. So it looked great, wasn't functional. So really looking at that. Making sure the grab bars and handrails are in good condition throughout the building and that they're easily visualized. A lot of times you try and integrate them in because you don't want that medical appearance, but we need it. They need to be able to see where those handrails are. Making sure you have clear, bright lit walkways. And very important to have those contrasting colors. In the resident's room, make sure the room is set for safe mobility. So proper egress height of the bed and mattress is that the feet are on the floor and that the knees are just slightly above a 90-degree angle. Again, most falls are around or near the bed. The bed should only be put in a low position if the resident cannot physically get out of the bed anymore and is a roll risk. But if they physically still are capable of getting out of that bed, if you put in a low position, I guarantee they will fall because they're not going to be able to get up. So ensuring that the bed height is appropriate at all times, that they have grab bars or trapeze to help them move and safely and securely balance themselves. And then making sure their walkers and canes are at the right height, fitted for them, and are accessible right at that bedside for them. Make sure they have a clear path to the bathroom with the right lighting. And then make sure they have the grab bars, the right seat, right height for the toilet seat. Maybe even for turning the water on, they might need extra little grab hand bars to be able to turn the water on and off themselves. And very important to have a contrast in the bathroom so they can see the toilet. If you have a white floor, white toilet, white wall, they're not going to find the toilet. So even as simple as a black toilet seat can help with that. I also recommend the investment in stand assist devices and have them dedicated to restorative nursing and even in therapy. So even like your sit-to-stand lift, where if you have those, again, folks that have some balance issues, but they can stand and bear weight, it's just a balance concern. Again, you can put them in those stand devices so they can exercise in that weight-bearing position. Make sure you have accessible exercise equipment. I go to facilities that have beautiful gyms, great equipment. No one gets to it. No one ever uses them. You don't need anything very expensive. You can just use, in the next couple slides, which I'm not going to go through, they're self-explanatory, are just the simple tools. Your own body weight and a little bit of resistance is all you need to have a therapeutic exercise program. And that way you can provide enough exercise tools for, having groups of 4. So your little dumbbell weights or resistant bands, things like that. So the next slides just give you some ideas of some equipment you might want to consider to actually invest in. From there, make sure, too, they have appropriate footwear at all times when they're working out, and then making sure you protect the skin from skin tear. So lotion skin and maybe long-sleeved or protective garments when they're working out. And then very important, get input from the family members and the residents. How do they like the programs? What would they like to do? You might be surprised how many family members are personal trainers and would help with the actual program. So getting their feedback and having them actively involved, and they can even come in if they have competency testing. Many of us have that guilt of putting that loved one in the nursing home, and if they knew they could come in and do mom's exercise program with her, what a great way to be actively involved. And then last but not least, once you kind of get that going, if you do want to look at promoting a sleep, some key things you do have to get in place is at night, you should only use amber tones because that will help promote melatonin. You don't want bright lights because that promotes serotonin, so that's going to keep the residents awake. So look at the lighting. Make sure there's no noise waking people up. And then if we're going to let them sleep uninterrupted safely, we want to make sure they don't get pressure ulcers, so you have to have aggressive support surfaces. Make sure those heels are up off the bed, that they have appropriate aggressive overnight incontinent products, and that they're allowed to sleep at least 4 hours or more. Really, your end goal is keeping residents active during the day and promoting sleep at night. So with that being said, I got some resource sources here and the references to that, the effects of immobility studies that I went through the first part, and I only hit the tip of the iceberg of a lot of the effects. So if you do take the time and read those over, they're very, very interesting to read. So with that being said, I'd like to turn it over to questions.
Thank you very much, Jeri.
You're welcome.
And so there's a lot of great information. So, operator, if you can remind everyone how to get in queue for questions or comments.
Absolutely. If you do have a question, please press star 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. And it looks like our first question is from Christina Vos. Christina, please go ahead.
No, I'm sorry. I was trying to mute my phone, and that's what we do to mute them. So I don't have a question. I'm so sorry.
Well, hello.
Hello, thank you. But I don't have one. I'm sorry. Thank you.
All right. Well, our next question is going to be from Larissa Rolfe. Larissa, please go ahead.
I'm just wondering if we can get a copy of the slides that were presented today.
Jeri, that would be up to you. I mean, the handouts are available, but I don't know if you want people to actually have your PowerPoint slides.
Not the PowerPoint slides, but the handouts are just fine.
I'm putting the link for the handouts again in the chat.
Okay, that would be perfect.
All right. And our next question is from Tamara Burdett. Tamara, please go ahead.
Actually, that was my question, too, so.
Great.
Okay. Our next question is from Cindy Gall. Cindy, please go ahead.
My question is, you talked about therapy in groups of 4 or less. So you're saying that we cannot do large groups, we can't count large groups.
You can't count, right, in the restorative, so if you are doing things and activities where it is a large group, unfortunately you can't count that, but please still do it. But if you are trying to track it on the restorative, it has to be a group of 4 or less.
Thank you.
And it's a safety issue when you're doing those specific individualized exercises versus maybe activities of doing maybe a Tai Chi or, ball throwing or whatever.
Thank you.
You're welcome.
Next question is from Mary Brown. Mary, please go ahead.
When you were talking about the individual or the goal test for the benchmark, I guess I want to know what the chair rise test consists of and the balance for the usual gait.
It's part of it's part of the SPTD test. There's the 3 tests in there, and I guarantee you your therapy is probably already doing those tests. So you certainly can ask them if they have it. If not, I've got a physical performance test that we use where it's integrated in that, if it's on information. But I would see if your therapy has it and if they're using it for benchmarking, because then you'll have good benchmarking from, when they came in to turning over to nursing. I guarantee you they have access to it and should know where it's at.
So these are just certain tests, or is it like any chair test?
Nope, it's the chair-rise test is what you do is you time the person, so you sit them in a chair at the appropriate, height for their feet and, their legs are 40 or 90-degree angle. And what you do is you have them try and stand up without using their hands, and you time them. And what you want them to do is stand up and down as fast as they possibly can in the chair anytime, and that's what you're looking at is their ability, to not use hands or other weight, if they can just physically get up, and then how quickly and how many of them can they do in a minute.
In a minute, okay.
Yeah.
Jeri, there's a question in chat. Any suggestions for how to drive your quality measure down for the loss of ADLs? I'm guessing your response is everything I just talked about, but looking for a few tidbits to pass along to my nursing homes working on this issue.
Well, that's one of the things. So if your QMs are plaguing in that area, first I would do a little investigation. So I would look at who had shown a decline in the ADLs, and I always start with, first of all, you got to see in your data. So scrub it first, make sure it wasn't a coding issue, and it gets a little tricky on the ADLs with the MDS because you might have somebody that's actually very independent during the day, but at night during that 7-day look period, they maybe had a couple instances where staff actually helped them. So you code it at that highest level, and so sometimes it might look like they maintained or even declined when actually, nope, they used to need assistance throughout the whole day where now they did it. So that piece gets a little bit sticky. So I would look at who's flagging for decline, look at how they were coded, and then also look at what areas that they're declining in so you can kind of target that. And then the biggest thing is getting them mobile is where you're going to hopefully prevent mobile and independent so staff isn't having to turn and reposition them or isn't having to have to vary anyway with a transfer, et cetera. Hopefully that makes sense. If not, take back in.
Thanks, Jeri. I think our time is about up, but there's one more question on chat. Isn't it true that large groups can be done as long as there is a 4-to-1 ratio of patients and staff?
Yes, absolutely. Absolutely. So you can have people kind of, throughout the room and you have your little groups of 4 and yes, so as long as it's that 1-to-4 ratio within those big groups, yeah, absolutely, you can do that. It's just making sure that that's the 1-to-4 ratio is actually being met.
Thank you very much.
Good clarification. Now, if you've got further questions, my contact information there. Certainly get me a hold of Stratus, and they can definitely know how to find me as well.
Thank you very, very much. Lots of great information, Jeri. We appreciate it. And thank you to all the organizations that participated in this webinar. We had a great turnout, and I hope you can all take a lot of what you learned back to your homes to really improve the quality of life of your residents. Hopefully you saw there was some polling questions that came up on the screen. I hope you had the opportunity to answer those. This concludes the webinar, and everyone, you have a really great day. And thanks, Jeri.
Thanks.